Welcome to PEM CHATT. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Well, welcome, PEM CHATT listeners, to today's episode all about the febrile neonate. Now, today is going to be part one of a two-part series on fever. Today, we're going to talk about the febrile neonate, but then in part two, we're going to discuss a fever workup in children 3 to 36 months. Fever management in pediatrics is easily the bread and butter of what we do on a daily basis. So being comfortable with this topic and having an evidence-based approach is paramount for your success in any setting, whether you're in the emergency department, urgent care, or even in a clinic. So if you're new to clinical medicine, you may not know this, but in the past, febrile neonates were managed very differently than they are today. At one point, every single baby that came into the emergency department with a fever of 100.4 or greater from birth to 3 months of age got a full septic workup. Now, we're going to break down exactly what that means here in a few minutes, but I'm talking about blood, urine, CSF, antibiotics, and admission to the hospital for every single one of those babies. Now, it's 2025, and we've had lots of advancements in medicine. So we have better vaccines. We have better viral and bacterial PCR testing, so we get it back immediately. We have better maternal surveillance, so they're watching for GBS and treating that more aggressively. We have improvements in our food supply, specifically like we don't have as much listeria in our food supply. And then we have better research about these babies, who needs treatment and who doesn't. So with all of that combined, the AAP published new recommendations in 2021 about how to manage a febrile neonate. And I'm going to link that article into the show notes today so you know exactly what we're talking about, along with an algorithm from CHOP on how to manage a febrile neonate. So despite any guidelines, this type of patient can be incredibly intimidating, particularly if this is something you don't do on a daily basis or you're a new provider. So I'm really fortunate to be here today with Dr. Lindsay McHale, and we're going to be discussing how exactly to approach this workup, what tests we need to order, how we're going to interpret those tests, and what a typical plan of care for febrile neonates looks like in the emergency room. So welcome, Lindsay. It's been a pleasure having you and your husband join us in our team just a few years ago and watching your little family grow. So before we get started, just tell us a little bit about yourself.
Thank you for having me, Toni. Happy to be here. My name is Lindsay McHale. I am a pediatric ER physician here in Chattanooga. I completed my pediatric residency at Le Bonheur Children's Hospital in Memphis, Tennessee, as well as my pediatric emergency medicine fellowship. I moved here with my husband, Mike, in the summer of 2023 and started my first job as an attending. Worked here for a couple months and then had my first child. I went on maternity leave and then came back and just had my second child, who is now almost 8 months old. So have 2 girls under 2, Amelia and Charlotte, and a golden doodle named Wilson. And we have really enjoyed getting to know the people here in Chattanooga. We love the community. I love the people I work with. It's been a great move for us, and we are happy to be here.
Yeah, and with 2 little bitty ones, I can't believe you even found time to do this. So thank you.
Yeah, I really, I thought about, what are my hobbies? And I really don't have many hobbies right now. They're mostly my children, but
Yeah,
maybe I'll pick some up eventually.
it does get better. It does get better.
Yeah, that's what I hear.
So how do we define a febrile neonate? What does that mean?
Yeah, so the definition technically of a neonate is any baby less than 29 days old, so 28 and younger. And fever is defined as a temperature of 100.4 degrees Fahrenheit or higher. And typically for us, that means that temperature of 100.4 measured either at home or in our emergency department or at the pediatrician's office. Oftentimes, parents will come in and say that their baby felt warm. There are studies to show that that can be reliable. But most of the time, if a parent says that they measured their baby with a forehead thermometer, I don't take that as seriously, especially if they say it was like 100.0. But if the parents seem reliable and they said they checked the temperature rectally and it was 100.4 or higher, even if they're not febrile in our emergency department, that is a febrile neonate and we proceed as such.
Yeah, we believe our parents. But we
Definitely.
also like a measured temp, right? So what do we do, with a kid that comes in and the parent says they felt warm, but they don't have a measured temp? They look really good. How would you manage that patient?
So I think everyone's a little different. In my practice, what I do is obviously if the baby looks great, temperature is maybe 99, 98, we will go ahead and watch the baby in the emergency department for an hour, let the family just do what they do, feed them, and then recheck the temperature in an hour. If we recheck that temperature and they still don't have a fever, we watch them for another hour, check it again an hour later. And if I have two to three solid documented temperatures that they do not have a fever, then I feel pretty comfortable if the baby's still feeding well and looking well, sending them home with close follow up with the pediatrician within the next 24 hours with very strict return precautions. And if they were to develop a fever at home, 100.4 rectally, I would want them to come immediately back to the emergency department.
Yeah, and I find that's pretty standard in our group. What about cold babies? Do they fall into this category?
I would say cold babies are a little bit more difficult just because we don't have a hard cutoff. I think some people do. They use 36 degrees Celsius and they say that or low. If they're below that, I'm doing the full workup on them. For me in my practice, if they're 28 days or lower and they come in below 36, I'm pretty much doing the full workup as well. I think in our babies that are a little bit older, I will have mom bundle them up, watch them for another hour if they don't drop any lower and they're feeding well, possibly not do that lumbar puncture. But if they're below 36 degrees, I'm typically doing at least blood and urine and likely a lumbar puncture.
Yeah.
And that's assuming there's no other risk factors.
And there's a lot of controversy here. I recently presented on late preterm infant with a neonatal nurse practitioner, and they have some pretty hard and fast rules with regard to temperature, but their babies are under warmers. And we see these babies that are like naked at the pediatrician's office for, 30 minutes or whatever, and they're cold and they look good when they come in. And so lots of discussion and differences between attendings, I would say, with regard to how like cold babies are managed if they're well appearing. Obviously, and during this podcast, we're going to be talking about well appearing babies. So if you have an ill-appearing baby, that's a totally different category. Those babies are going to get all the things. But yeah, definitely a matter that we still discuss in the ER a lot, like what temperature is cold versus not cold. And when you look at the literature, there's not really good guidance yet. Is that your understanding too, Lindsay? And
Yes,
I
I
think,
definitely agree with that. And there are certain clinics we get a call in and we know they check every baby's temperature rectally when they walk in the door. And that's not really our standard. We don't recommend that. I don't remember, I don't think either of my children have ever gotten a rectal temperature at a regular well child appointment. So I think if the baby is doing well, that's another thing I tell parents you don't have to religiously be checking their temperature at home because then that sets us up for significant workups in a baby that otherwise might not need it.
when we have babies that are in this age group, this less than a month old, and they come in and they have a fever, can we treat the fever?
Yes, please treat the fever. So I think a big misconception, and often when we take calls again from either clinics or other outside community emergency departments where people might not be as comfortable with treating children, people are scared to treat a fever. And I think that all probably comes from us telling parents if your child has a fever at home, they are 28 days or younger, and you check it rectally, it's 100.4. Don't do anything, come straight to the emergency department.
Right.
I think that's because we don't want them to mask that fever at home. We don't want them to give Tylenol and treat it without them being seen by a healthcare provider. But once they come through our doors and they're under our roof and they have a fever, we know they have a fever. It's been documented. We are evaluating them. We are getting the blood work. We're doing the cultures. So, yeah, let's treat the fever because that baby probably doesn't feel well. They might not be feeding as well. They're probably a little bit more fussy. And so we want to treat that fever to help them feel better. And so, yes, we do recommend giving Tylenol. Again, any baby under 6 months old is too young to have ibuprofen. But yes, Tylenol, 15 milligrams per kilogram, either rectally or orally every 4 hours, we treat.
Okay, so we're going to kind of move in and talk about this protocol, but there's definitely like some strict inclusion and exclusion criteria with regard to the algorithm. Can you tell me which babies we're going to be talking about for this algorithm?
Yeah, if a baby comes into the emergency department, they first off have to look well. Any baby that is ill appearing, whether they're mottled, apneic, profuse vomiting, lethargy, any of those buzzwords, you see that baby, they are automatically not in this category. You already know you're doing all the things. So we are talking about the baby that is full term, so greater than 37 weeks of age, no birth complications, no prolonged NICU stay, maternal GBS negative, and talking with mom, no history of fever at delivery, no history of chorioamnionitis. Essentially, this baby was born full term, looked well, went home with mom, has been doing well at home, and they just have a fever and they come through our doors. Another thing is social barriers we want to look at. If If this family is a very reliable family and we know that they have good transportation and a pediatrician, then we feel a little bit more comfortable about this family and we're going to proceed as such. But if this baby looks sick, that's not who we're talking about today. We already know what we're doing with the sick babies.
So this is a pretty aggressive approach to a kid with a fever with regard to like when you compare it to older kids. So why do we treat neonates differently? Why are they in this like risky category that needs more things?
When a baby is born, they essentially have no immune system. They have not been exposed to the world yet, and they have not come into contact with anything really. And so they don't have a way to defend themselves against viruses and bacteria. So they are risky to begin with. Also, they're not vaccinated yet. So, these babies can get sick very quickly. They're not like you or I, or even an older child where they start to have symptoms and then they can progress and then they start to look sick. These babies can go from looking perfect to looking miserable and being on death's door within hours. And the other thing is sometimes these babies don't look sick. You can have a meningitic baby who comes in and just has a fever. They don't present the same way because they don't have an immune system. They don't build those same symptoms in the way that an older child might. So because of that, I always tell parents we don't trust babies. And so we do all the things when they come in and they have a fever.
So because this is such a risky population and we do so many things, this tends to be a metric visit. I can't speak to every ER in the country, but I think pretty widespread this is something that is monitored and metriced by hospitals. So what is our goal when we're approaching this patient?
Yeah, so we have something called a code 60. And so there's a few different patients that fall into that category. Kids that come in with fever with a central line, febrile neutropenia, and then our febrile neonates are also one of those big ones that we see probably the most frequently in this category. And what a code 60 means for us is our goal is to, from the moment they check in until the moment they get antibiotics, we want to do that in under 60 minutes. And so when they check in, we know we have to get an IV, get blood work, get blood cultures, get urine cultures, CSF, and start those antibiotics within 60 minutes. And there's data that shows that we have definitely improved outcomes and mortality in patients with sepsis and meningitis that get early antibiotic administration. So that's why we have those measures in place and we really try to stick very closely to them.
So let's walk through one of these visits, kind of a hypothetical for you, but you're at work, you hear a code 60, you are alerted to look at our census, you see there's a febrile neonate on the board. She's 6 days old. The nurse's note or the chief complaint says that the parents noticed she was fussy and she felt a little warm. They called their pediatrician's office and the pediatrician said, you need to go to the ER. And when they got here to the emergency department, her temperature rectally is 100.8. Her other vital signs are normal. So you're going to pick this patient up and go see them. Tell me what you're thinking about as you're headed in to see the patient.
Yes, typically when this happens, by the time I'm in the room, the nurses are already in there starting an IV, getting that blood work, maybe even already doing the cath for the UA. Our nurses are pretty good here. They know code 60 is super important, and we will get frustrated if we sit around on these patients. And so, as the nurses are doing this, I will frequently be multitasking as well, trying to get the history from the family, sit down with them, see what's been going on. And then also in that same encounter, I'll try to get consent for the lumbar puncture. Because again, we have 60 minutes to get all of this done. It's a lot to get done in a short period of time. And we know that it's important to get those antibiotics in. And I find that lumbar puncture and talking the family through it most of the time is the biggest barrier to that. Common things being common, most of these kids are going to have the same viral thing that their older sibling has, but we can't miss sepsis or meningitis in these babies that can be hiding in the mix. So just because you have rhinovirus doesn't mean that you can't also have meningitis. So yeah, I'm thinking about the serious things that can kill the baby and that we want to take care of as quickly as possible while I'm talking to the family.
So you're in the room, you've collected this history, you're getting a look at the baby, and you're talking to mom and dad. What are your first priorities? And walk us through how you're going to talk to them.
So I think the biggest thing and something that I learned probably as an intern in pediatric residency was you need to know what sick and not sick looks like. And that was drilled into us. And that's for me what I'm thinking. The second I walk in the room, I'm immediately looking at the baby. Is this baby well appearing, resting comfortably in mom's arms, sucking vigorously on a pacifier? Or is this baby laying there, not really moving around much, grunting or screaming, inconsolable, These are the types of things that I'm trying to figure out immediately when I walk in the room. And then also doing my quick head to toe assessment on the baby while I'm also talking to the parents. And then talking with the family, telling them why we're concerned about a fever, what a fever could mean in this baby, that we need to look in all the areas, blood, urine, as well as the CSF, where infection could hide, and laying out what that looks like for the family. After having this conversation, probably now I've been in attending for only a couple of years, but I've probably had this conversation at least 100, if not 200 times already throughout training. I think the biggest thing that I found as a barrier and I guess an area of concern for parents is neurologic damage. Are you going to hit the spinal cord? So, a way that I've found to kind of help parents from the beginning understand what we're doing and what a lumbar puncture means is actually drawing a picture for them and showing them this is where the needle goes. It's going way below the spinal cord into that area, the cauda equina, down where there's only fluid. I'm not going anywhere near the cord. There's no chance that I'm going to hit their cord and cause them any nerve damage. Once I draw that picture out and show them where the space is, I often explain to parents the position that we put them in is very important. They have to be laying on their side. Some people have the baby sitting up, but I prefer side lying. And I tell the parents the worst thing, as far as it is from what I can tell, is the baby being scrunched up in that position and they don't like it. And so they cry when they're in that position. But as soon as that needle gets in, most babies fall asleep. I think another big thing is managing expectations and letting the family know, no, my goal is to get this on the first try. I only want to stick your baby once. Down here, we are in the emergency department. Your baby is small. The space that we're going into is small. Sometimes we can't get that fluid immediately. So I'm going to try up to 3 times. And after the third stick, if I don't get it, I stop. We start antibiotics. We move forward. Sometimes the inpatient team will try to get the lumbar puncture when they're upstairs after they had some fluids. Maybe they're a little bit more rehydrated, but I will not keep sticking 5, 6, 7 times. And again, the goal is the first attempt, but if you can't get it on the first try, I don't do more than 3. And then I also allow the parents to stay in the room if they want to. I think, they feel very out of control in these situations. And so giving them a little bit of control and letting them make that decision, I found is helpful. Some say, nope, absolutely not. I don't want to be here. You do what you need to do. I'll come back. I'll go to the waiting room. Others say, yes, I'm not leaving my baby, which again, now that I'm a parent, I completely understand. I just tell them you have to remain seated and wear a mask. But I think once you draw the picture out, explain the risks and ultimately the benefits, I'm trying to make sure that your baby does not have a bacterial infection around their brain and spinal cord that could cause some serious lifelong damage if we don't catch this right now. Most parents are pretty amenable to letting you move forward and doing what you need to do to take care of their child.
How would you approach the family? And I feel like I ran into this recently. That's like, can we just like do the blood work and urine and wait on the LP? Like, can you make a decision after we get some of that testing back? Like, what if he just has RSV?
Yeah, so that's a hard one. This is scary for parents. They took their temperature in their brand new baby that they just got home with at home, and it was 100.5, and they look well and they come in, and all of a sudden they're being told that they need an IV and they need a catheter and they need a needle in their lower back and they need antibiotics, and now they're going to stay. And, what are we going to do with our kids at home? And so, there's a lot of things that parents are scared about. And so I will try to sit down and figure out which one of those things is making them hesitant. Like, why are they scared specifically? And then again, explaining my goal is to protect your child from a serious infection. And if we can get the blood, urine, and CSF cultures, we can feel confident that in 24, 48 hours, if those cultures are negative, your baby can go home. If we don't get the CSF, there's a chance that we could be committing your child to up to 2 weeks of IV antibiotics here in the emergency department. And the other thing is, again, code 60. We have 60 minutes to get all of these labs obtained and start antibiotics. And the longer we sit and talk and debate, we're wasting time to get those antibiotics in and take care of your child. And again, just reiterating, your baby has no immune system. They don't have a way to fight things like you or I do. And sometimes a fever is the only way that we know that a baby is really sick. So again, when you sit down and try to figure out why they're so scared, what their concern is, and then explain why we do what we do, most parents are amenable to letting you move forward.
Yeah. And we also don't make our clinical decisions based on the blood work, right? Like this isn't a
Right.
stepwise approach. We have to get
Nope.
the
We
cultures
need it
for
all.
all three fluids as soon as possible. So, with regard to the workup, we've kind of touched on this and we keep saying it over and over again. We're going to get urine, blood, and CSF so we can get cultures. But there's other testing that we do for these babies. What tests are we ordering? What does this workup look like for this baby?
Okay. Blood work. We're getting an IV and we are getting a CBC, often a CMP as well, blood culture, CRP, and a procalcitonin. Procalcitonin is a little bit of a newer lab that we've been using, I guess, in the last few years. CRP has been around a little bit longer, but there are studies to show that procalcitonin it can be normal in viral infections and more elevated in bacterial infections. So it can be a little bit more specific for us. We usually get both. When it comes to ESR and lactate, we don't usually order those. Those are more outside facilities. We'll frequently order those on these babies, but I don't typically order an ESR.
Do you think
The
because they
Procal.
don't have the Procal? Like some hospitals, you can't order a Procal.
Yeah, I definitely think that's possible. I think Procal seems to be more of a pediatric lab and they just maybe don't order them as much in adults. I think it's probably the opposite. They order more ESRs in adults. And really, the only time I'm ordering an ESR is on like a possible septic joint or something that's been going on for a little bit longer. Yeah, I think, again, because Procal's newer, maybe they just don't have it at these outside facilities.
Hmm.
But that's the blood work we're getting. As far as urine, we definitely want a cath urinalysis. Babies pee a lot, and oftentimes if we look at the urinalysis, it might be normal. There won't be any positive leukocytes or nitrites. And so we definitely want to get that culture because the culture could come back and show that we have greater than 100,000 colonies of E. coli, and we had a normal urinalysis. So we really want to get that cath urinalysis. And then, of course, our lumbar puncture for our CSF studies, we're looking at the protein, glucose, cell count, and then culture. And ultimately, the most important thing, in my opinion, for all of these is the culture. We need the cultures. So we're hoping to get at least enough fluid for a culture. If you do a lumbar puncture and you only get a few drops, please send the culture.
Hmm.
And then the other thing, considering concern for HSV, talking with mom. Did she have active lesions at time of delivery? Does she have a history of HSV? Other things we're looking at outside of all of the things that we just spoke about that you're 100% getting. If they're having cough, congestion, or any respiratory distress, we'll often get a chest x-ray as well as an RVP, and then giving them fluids as needed, D10 as needed if their sugar is low, and going from there. And then we also have the meningitis encephalitis panel that we send and looks for a bunch of different bacterial and viral causes of meningitis.
Are you in the boat of people who order meningitis encephalitis on all of these babies, or do you wait on the cell count and then make a decision?
I don't know if I have like a strict answer to that. I more often than not, I guess I think I am ordering it mostly because all these babies are getting admitted and the admitting team always asks for it.
Hmm.
Not to say that that's why we should get it, but I'm interested. I want to know. I think if their cell count is completely normal, the chance of them having a positive panel is pretty low. I don't know if I've ever seen it, but it's an easy enough test to send. These kids are staying here in the ER. It comes back really quick. I am in the boat, yes, of most of the time I'm ordering it.
Yeah. All right. And we order antibiotics on these kids at the door. So, what are we typically ordering on these kids?
Yeah, so we are concerned for E. coli, group B strep, and listeria in these babies. And so to cover the E. coli, we want a beta-lactam antibiotic, often either cefepime or ceftaz. And then to cover group B strep, we use ampicillin, and this covers listeria as well. Historically, listeria and group B strep were more prevalent, but E. coli is now the most common cause of fever in these babies, I guess bacterial infections in these babies. The guidelines recommend ampicillin and either a third gen beta-lactam or gentamicin. And so our third gens, again, are ceftaz or ceftriaxone. Here we do ampicillin and cefepime, which is a fourth generation. Talking with our pharmacist and asking her why we use that. She said it's easily made at my hospital in Lebanon. Pretty sure we did ceftaz. But yeah, ampicillin and cefepime are what we do here.
Yeah, and that's going to vary from facility to facility and be a little bit different regionally. When you look it up on Up to Date, they say AMP and GENT in your early onset sepsis, so that's your 0 to 3 days, and then AMP and usually a cephalosporin for your babies that are older than that. But even in the early ones, we're doing the AMP and cefepime. Have you seen anybody use GENT recently?
Can't remember the last time I ordered it.
Yeah, and I looked at the CHOP algorithm, in preparation for this, and they're doing the same. And these antibiotics choices change if you have an ill appearing baby or a baby that looks septic.
Right.
But we're just talking about these well babies. Okay, great. Antibiotics. There's a little nuance in the dosing of these antibiotics. Like if you were going to use ampicillin for pneumonia versus one of these babies, and people talk about meningitic dosing. What does that mean to somebody
Mm.
that's never done this?
Yeah, so meningitic dosing, you want to make sure that your dose is high enough to penetrate into that CSF and to treat any bacteria that might be there. So those doses are going to be a little bit higher than something that would treat a pneumonia or a urinary tract infection. So for ampicillin, our ER dose here, we give 100 milligrams per kilogram, which is our meningitic dosing. And then that's followed up with either 100 mg per kg Q8 if they're less than 7 days, and then 75 mg per kg Q6 if they're greater than 7 days. And that's considered the neonatal meningitic dosing. And then for cefepime, we are doing 50 milligrams per kilogram, and that's Q12 once they are inpatient. And then, of course, we want to consider acyclovir if there is maternal history or any history concerning, and that would be 20 milligrams per kilogram Q8.
So in reading about this, I learned that then in some parts of the country there's resistance for the ampicillin, the cephalosporins. But I talked to our pediatric clinical pharmacists, and they said that they have not seen that in this area. Obviously, we are in Chattanooga, Tennessee, so that may look different in your area. I would suggest either talking to your attending or your pharmacist. Really, they're great resources and know what's going on with resistance patterns. And so, certainly checking to make sure you're getting the right antibiotic if this is not something you do routinely would be something I would definitely recommend. All right, so moving on to lumbar punctures, any tips or tricks you have to share with us on how to do these?
Yeah, so I know you've asked everyone what their favorite procedure is, and everyone says the nursemaid. I love a good lumbar
Me
puncture.
too.
It's definitely my favorite procedure. I think, and this is kind of the spiel that I always give our residents, the most important part in a lumbar puncture is having someone who knows how to hold.
Yeah.
Um, this baby is going to move and wiggle around, and having them in the best position possible sets you up for success. So, again, I do my lumbar puncture side lying. And so having the holder really have a good grip on their shoulders and on their hips and squeezing them hard when I need them to, curling them into that great C shape to really open up those spinous processes so I can get into the space. And then also when having them either tilt the baby forward or backwards so that their hips are in the perfect position for me. It's an art. I feel like some people just are really good at holding, and that makes it super easy on the provider trying to get that fluid. But also I tell the residents, do it the way that you feel most comfortable. Um, you know, you're in training, try different ways. And once you get comfortable with a way that works for you and you feel like you have the most success with that way, do it that way. So if I have second and third year residents who have already done a handful of lumbar punctures and they've been successful, I don't tell them what to do. I say, I'm going to watch you. I'll be here to help you. You go and do it yourself and do what you do. And I'm right here if you need help or need adjustment or have any questions. But doing it a way that you're not comfortable with can make it a lot more difficult. And then I always have the child on a monitor, and I have a non-rebreather on and active. At bedside just to kind of ward off anything that could happen. I've had a patient who desat and dropped their heart rate to 60 before. And so I'm probably, because of that experience, I like to have every kid on a monitor. But it's not typical that kids have issues. Most of the time, if they do drop their sats a little bit, you just uncurl them a little and they're fine. And then, lastly, don't be afraid to wait and stick until the patient is in the best position for you. If the holder is not holding them in a way that you feel is helpful, don't just go for it. Make sure you're setting yourself up for success.
Yeah, I think it's really interesting to talk to different people and see how they do it because there's so many different pearls from different sources. And Lonnie once said to me, I never thought about this before that. He was like, if you're left-handed, lay the baby on the right, and if you're right-handed, lay the baby on the left. And I'm left-handed, so, like, I'd never thought about that, and my success rate went up. And then it was Tom and Anna that really have gotten me to do this sitting up, version with babies, and I love it. I am a sitting up all the way kinda girl now, so I think I've probably been most successful in that position. And the secret to that is making sure that the baby is not crumpled too forward over. So you wanna make sure that their shoulders and their hips are kind of aligned and a more upright, and then their head is forward. Again, it's all about your holder and getting the right position. I also like the trick that I use with PA and NP students is I have them find the space, put their thumb on it, and then follow the needle right over the thumb. So you're not having to like mark a space, move your hands away, lose your position, just kind of leave it there. And then you can slide it right over your finger. And I've had greater success, especially with students when you're teaching that.
Sure.
Okay. So we're back to our little case with our baby, our 6-day-old baby. We have collected all the fluids. We have started antibiotics. We're starting to get results back. So let's talk about what we're looking at and how do we interpret all these things we're getting back.
Right. So when you're looking at your urine, it's positive if you have leukocyte esterase or if you have greater than 5 whites in your high power field. And this is, of course, with a cath urinalysis.
Yeah. That's
So
kind of
any baby
unique to
with that,
kids. The 5.
right, right. It's low. But yeah, that is a urinary tract infection if you have either of those. For our procalcitonin, it's considered positive if it's greater than zero point 0.5 micrograms per deciliter. And then for our CRP, it's positive if it's greater than 20 milligrams per liter. And then we're also looking at our ANC if it's greater than 4,000.
Yeah, and
Um,
sorry to interrupt, but in the protocol,
you're
they
good.
talk a lot about inflammatory markers, and this is that category, just to clear that up if it's not something you're used to talking about. And they also put the fever in that category, so they consider that an inflammatory marker, which is kind of unique to this population. So, anyway, just wanted to add that. Sorry.
Yeah, 38.5 or higher is a positive inflammatory marker. That is unique and interesting. And then I guess if you have a pleocytosis, so if you have greater than 20 white blood cells in your CSF, I have usually already ordered it. And so if I'm looking at that cell count, that panel is coming back pretty quickly afterwards.
One of the most common complications in this workup is you get a bloody tap. And there's lots of different ways to approach this, but what do we do? How do we interpret CSF fluid that comes back with red cells?
Their correction formula out there where you're looking at the red blood cell and the white cell in the CSF and the red cell and the white cell in the periphery, and you put it into a formula and it can help you estimate your true white blood cell count in the CSF. Um, I, I don't know how reliable that is. Most people, you rely on your clinical suspicion. You're going to be beginning empiric antibiotics anyways. Um, I think ultimately it's better to have bloody fluid than no fluid, and you can still get your culture with bloody fluid. It's fine if there's blood in there. If a provider calls me and said they got CSF, I'm happy.
Yeah. Okay. So we have run through what like a sepsis workup for a neonate looks like. But let's talk about this actual protocol that the AAP provided and some of the nuance of that, because we really moved away from everybody gets everything to breaking it up into these different time frames for babies. So the protocol is divided into 8 to 21 days, 22 to 28 days, and then a 30 to 60 day group. The baby that we just talked about was 6 days old. So she doesn't even have an algorithm in this protocol because your babies 0 to 7 get everything regardless. So there's no exception in that group for a sepsis workup. So let's talk about some of these other groups and what that looks like. As much as I appreciate the particular guideline, I do find it a little overwhelming. There's like it's I don't know what 25 pages long. There's a lot of text, then there's these algorithms kind of embedded in it. I love the CHOP algorithm. I refer to them for lots of different things because they combined all these different age groups into one thing, and then you can kind of follow it through. So I think it makes it a little bit easier. So if this isn't something you're doing all the time, I suggest looking at that. I'll put a link to that algorithm in the show notes also because it's very nice to use. And I don't want to oversimplify this, but basically, if you are less than 22 days old, you're getting all the things still, right?
Right.
Yeah, yeah. So, really that 0 to 22 days, you're getting all 3 fluids. We're doing a full workup. And then when we get into this 22 to 28 day range, there's a narrow window of like a little bit of wiggle room where you might not do an LP. But again, this baby is well appearing. You're still getting the blood, the urine, the inflammatory markers that we were just talking about. This is one where if they've had some congestion, you probably add an RVP and look to see if this is maybe a viral source that you can attribute their symptoms to. If there is an abnormality on your inflammatory markers, you're going to move forward and do the LP. What is your experience, Lindsay, with this age group, and what have you done with these babies in the past, this 22 to 28 day range?
Yeah. Again, the algorithm is long and it's pretty you can do this, you cannot do this. I LP every baby 28 days and lower that comes in with a fever.
Yeah,
And I really can't think of a time where I didn't. I think you know, it simplifies things. You don't miss things. I'm too new to really feel comfortable not doing a lumbar puncture in a 25-day-old with a fever. So yeah,
yeah.
I do it.
And you're in good company. I would say, of our, 12-ish providers, probably half of our attendings, they're doing it all. That we hear that statement, never trust a baby all the time. And so they're more likely to do this workup in this age group. And it really just depends on your risk tolerance level, being the attending and what you're willing to take a risk on. So a lot of nuance here. And if you look at this algorithm, again, it's a little overwhelming with the amount of nuance. I've actually only had this happen one time. And I was working with Shelly, and I was going in, this was a 26-ish day old, if I remember correctly. And I was going in to do all the things. And she said, hold up, do you want to do that LP on this baby? And I was like, oh, yeah, we're in that gray
The
zone
new
where
algorithm.
maybe I don't have to do it. And I went in and the baby was well appearing, fed well, looked amazing, had just the tiniest nasal congestion reported by parent. And there was some concern for a potential viral exposure. So I did all the things, the inflammatory markers, did the RVP. It turns out the baby had RSV. This was not a sick baby with RSV, so like not requiring support. The baby was not an extremis, looked great, feeding well. All the inflammatory markers were normal. And at that point, we'd switched attending. So I'm with a new attending, and we're going to admit this baby. And it became this almost like this council. So I called the admitting team, and me, the new attending, and the admitting team all sat down in a circle in the ER with the algorithm, talking about whether or not they wanted me to proceed with the LP. And in the end, we did not do the LP on that baby. So it was kind of a first for me, but it wasn't without quite a few brains coming together and making a decision. And the mom happened to be an ER nurse for adults. And so she was involved in this too. And so we talked to her, all of us, kind of made a decision jointly. Then we presented these things to her as well. And so everybody kind of weighed in on this. This was not a decision we took lightly. And ultimately we admitted without doing the LP. So it was kind of a unique situation. But yeah, a lot of people are not comfortable doing that. And so you're often going to be doing the LP in this age group too. Okay. So lastly, in the algorithm, we have this last group. So these are our babies that come in with fever again, well appearing 29 to 60 days. Walk me through how we manage those kids.
Yeah, so now you're out of that scary zone a little bit more. You have a little bit more leeway in this age range. You're definitely still getting a cath urinalysis and your inflammatory markers. But I think if the baby looks well, they're feeding well, we have our blood and urine cultures, the family's reliable, they can follow up. I'll send them home to follow up with their pediatrician within the next day or so without antibiotics. If their inflammatory markers are increased, for the algorithm, you may or may not do an LP depending on how increased they are and how the baby looks, etc. Again, I think this is there's a lot of pathways down the algorithm of what you can do and what you can't do, and it says a lot of times may do this, may do that. So I think again, it's case by case. A lot of factors come into play. I think if you are holding off, sometimes you can hold off on doing the LP and admit them to the hospital and observe them off antibiotics. I fall into the category of being a little bit less likely to give IM ceftriaxone and discharging home to follow up with the pediatrician. That is an option in the algorithm. If all of their inflammatory markers look okay, their urine looks great, they're feeding well, peeing well, and look well, you can give them antibiotics and send them home to follow up in 24 hours. But usually at that point, I'm again, this might be the newer attending and me talking, but I usually just admit these kids to the hospital, especially if most of these babies roll in on a Friday night and they don't have a pediatrician or they don't have follow up until Monday. And so I'll just keep them and watch them closely.
And that was what I was going to say. Like, if you're going to do that, it has to be the perfect situation, right?
Right.
It's got to be somebody you can communicate with that has reliable transportation and has a pediatrician that will absolutely see them the next day. Like, we might have to call and make sure it's going to happen. Like, just so many
Mhm.
things have to be perfect. But it's always, yeah, a Saturday at, 9 p.m. and there's no way you can talk to any of these people. So
Yep.
it's almost
So those babies
impossible.
just stay.
Or they don't speak English, or, they
Right.
don't have a car, they have to take the bus, and, there's so many things that go wrong with our patient population for sure. Okay, any interesting cases that you've had in this kind of genre to share with us?
Yeah, and that last question kind of made me think of this case. So we LP babies all the time in the emergency department. We, probably on a daily basis go through this whole algorithm and do all the things that we have to do. This was probably a month ago or so. I had a baby that I was seeing, 6-week old, X38 weeker, came in with a fever. They'd actually been seen in our emergency department, I think 8 days prior, 7 or 8 days prior, with a fever at that time as well. They fell into the category where they got inflammatory markers and urinalysis, and they were completely normal. So they did not, an LP was not warranted at that time. They were given IM ceftriaxone and sent home. They followed up with their pediatrician the next day. They looked well. They got their next dose of ceftriaxone, went home, did the same thing the following day. So got 3 days of IM ceftriaxone. And then had been doing well. And then the day prior to me seeing them for their second ER visit, started to have fever and fussiness again. They were put in room 3. And I said, there's a 6-week old in room 3 that has a fever that does not look well. And I went in the room, and that baby was, he was fussy. He was the definition of a fussy 6-week-old febrile baby. And I went to pick him up, and he had true nuchal rigidity. He was back arching. He did not want you to bend his neck at all. So we did the full workup on him. His meningitis encephalitis panel was negative, but he had elevated protein in his CSF. He had low glucose. He had elevated white blood cell count. So, all of the things to show that he probably had a bacterial meningitis, but the panel was negative. But he had had antibiotics 8 days prior for 3 days. And so we messaged infectious disease, and they said, this is probably a pre treated bacterial meningitis. This kid needs to stay for sure on IV antibiotics, and he ended up staying for a full treatment um, for likely culture negative pre-treated bacterial meningitis. So again, frequently this is not an abnormal case, but that is another reason why I get a little bit nervous to give these kids IM ceftriaxone and just send them home. Again, this kid looked great, and I went back through the notes and even spoke with a provider who saw them 8 days prior. They're like, "Did I do anything wrong?" I was like, "No, like, you followed the algorithm. You did everything right. Like, the baby looked great at that time. Just sometimes these things happen, and we handle them." But, that was an interesting case for me.
Yeah. I always like to stress with these babies that, like, you can always have more than one thing too. These are babies with no documented medical history because they're new. So we don't know if they've got an underlying congenital heart disease or they've got something else going on, or if there's been trauma at home, there's an NAT involvement. I love the misfits mnemonic. Is that something you guys learned?
I don't know. Tell me and maybe I know it.
I'll add it on the show notes, but basically it's for neonates and like considering all the things on the differential. So thinking about metabolic abnormalities or
Mhm.
hypoglycemia or hypothermia. I think one of the most interesting septic baby kind of workups I had came in as a hyperbilirubinemia. And so they just like here for a Billy check. But when I got in there and really got a history out of the parents, the baby was like intermittently turning blue with feedings, and we check a temperature in the ER and the baby's hypothermic, and so it ended up being a huge workup. It was definitely a kid that, like you described earlier, desatted during the tap and ended up in the PICU, and it was a
Yeah.
whole big deal. But anyway, I just like to stress that these can be complicated, so get help when you need it. Get your attending, get your pharmacist, get your intensivists involved when you need them. And if you're in an outside facility, you can always call your children's hospital. And we are frequently talking to people on the phone and helping them through these workups. So don't be afraid to call us. All right. Anything else you want to add, Lindsay?
I don't think so. Thank you for having me on. This was fun.
Yeah.
My first podcast ever. I guess I'm famous now.
Yes, you can consider yourself PEM Chat famous.
Awesome. Thank you so much, Toni.
So thank you to all the PEM Chat listeners that are out there today listening to us talk about how to work up a febrile neonate. Join us next time when we are going to talk about fever management in the 3-month to 36-month range. So this is probably literally the most common visit you're going to see in the emergency department. And we're going to break down an evidence-based approach to these patients. So join us next time here on PEM Chat. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.